Okay, good afternoon, everyone. Thank you so much for joining us for this month's Teach Educational Rounds. Here with us today, we have Kevin Haynes, Jama Yusuf, and Safia Jama, who will be presenting on improving cessation outcomes within Black communities in the Greater Toronto Area. So we're going to begin today with CAMH's land acknowledgement. CAMH is situated on lands that have been occupied by First Nations for millennia. Lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of CAMH appeared in the Colonial Records Office of the British Crown as the council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase, Treaty Number 13 of 805, with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. CAMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. Now I invite everyone to introduce themselves in the chat and let us know which traditional territories you are joining us from today. If you are unsure, I will send a link in the chat that you can use to find out. You're also welcome to let us know something you are doing to learn or improve your commitment to reconciliation. So I'll give everyone a few minutes to do that, and while people are sharing, I will share a bit about myself. So my name is Rachel, and like CAMH, I am currently located on the lands of the Mississaugas of the Credit, which is covered by Toronto Purchase Treaty 13. I'm a second-generation Canadian. My parents moved here from Ghana and Jamaica in 1990, and they settled in the north end of Toronto, where my brother and I grew up. I am committed to reconciliation. I continue to listen and learn about the stories and cultures of various Indigenous communities and ensure that their voices are heard. So I can see that Elk is joining from Six Nations territories. Thank you for sharing, Elk. And feel free, everyone, to keep on sharing in the chat, and I'm just going to continue on with a couple of housekeeping items. So if you are interested in receiving a letter of completion for this Teach Educational Rounds, please make sure you have registered for this webinar and completed the pre-learning assessment. As well, make sure you have signed into this webinar using your full first name and last name so we can track your participation. And finally, make sure to complete the evaluation and post-learning assessment, which will be emailed to you by the end of tomorrow, and you will have 1 week to complete that. Please note that a copy of today's presentation slides will be sent along with the recording by tomorrow as well. So here's a little bit more information on our presenters today. Kevin Haynes is the Provincial Network Lead for the Substance Abuse Program for African and Caribbean Canadian Youth and a co-investigator on the HCCF project. Jama Yusuf is a research coordinator at CAMH in the Nicotine Dependence Service, where he primarily works on the HCCF project. And Safia Jama is a community-based service provider and a Master's of Social Work student in the Substance Abuse Program for African and Caribbean Canadian Youth. And here is a list of their disclosures. And please note that the content of Teach Educational Rounds are centered on evidence-based guidelines from the following sources. And nonetheless, these materials, as well as the verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare providers. And please feel welcome to use the chat feature throughout the webinar to post any comments or answer any prompts from the presenters. To do this, you can click on the speech bubble icon in the control panel, and please ensure you select everyone so that all panelists, hosts, and attendees can read and respond to your comments. You are also welcome to use the reaction feature if you feel like sending a smiley face or a thumbs up. And all content-related questions will be answered at the end of the presentation, so please keep note of anything that comes up, and then you can post them in the chat during our Q&A period for our presenters to answer. And with that, I will let our presenters begin their presentation.
Perfect. Thank you so much, Rachel. And hello, everyone. Thank you all for joining us today. As Rachel mentioned, my name is Jama, and I'm a research coordinator research coordinator at the Nicotine Dependence Service here at CAMH. I'm also going to give my other two panelists an opportunity to introduce themselves.
Thanks, Jama. So I'm Kevin Haynes. I'm the provincial network lead for SAPSI, which is our substance abuse program for youth who identify as African, Canadian, Caribbean, and/or Black throughout the province. And I'm happy to be here to collaborate.
Great, and I'm Safia, and I am a community-based service provider, but then also an MSW student in the SAPSI program as well.
Perfect. Thank you both. And yeah, today we're going to be talking to you about our project called Improving Cessation Outcomes within Black communities in the Greater Toronto Area. So I just wanted to share some learning objectives with you all, and we understand, as Rachel mentioned too, that this is by no means will make you an expert on any of these concepts by the end of the webinar, but what we want to do is encourage more intentional conversations around them and to really jog your brain and your curiosity about smoking cessation outcomes within Black communities in Canada overall. So therefore, by the end of the presentation, you'll be able to discuss the impacts of race and culture on smoking in Black communities, examine different approaches to interventions that have shown results in smoking abstinence rates amongst Black populations, and describe recommendations on how to improve smoking cessation rates among Black populations as well. So I'm going to pass it off to Safia to kind of lead us on into the next question, and I'm going to share my screen.
Thanks, Jama. And so with that piece, I think the first piece we wanted to do was have an interactive component. So if you can go on menti.com and use the following code 892199596, we'll just give you a moment to kind of plug it in there. And our question here for you to answer is, how would you describe your current understanding of smoking and smoking cessation rates within Black communities? So we'll just give you a moment to do that. Yeah, just as it plugs in there, and yeah.
I'll give it about 10 more seconds before I stop the voting.
Yeah, it looks like it's just pouring in there.
Yeah. Okay.
Okay.
I will close the voting and I'll share the results as well.
Okay. Well, we have quite a few different responses. It looks like people are trying to get a better understanding, and hopefully by the end of our presentation, this might be helpful. Maybe what we'll do is go to the next slide. So the first piece, maybe to kind of conceptualize how the relationship between race and culture, we do have a couple of points here. So the first piece just to note is that Black adults have a smoking prevalence that is half of that of white individuals and adults. And then they also smoke fewer cigarettes, but are more likely to die from smoking related diseases than white individuals. The other piece to conceptualize and to think about when we're looking at this connection is around tobacco companies and how they've disproportionately targeted Black communities in their marketing and their promotion of tobacco-related products, like menthol, for example. And then the last piece here, just to think about, is that most programs, when we think about how they're designed, are that are designed for marginalized communities specifically, are often not grounded in their voices. And community consultation, as we know, is really important in the involvement around programs. So community consultation and involvement has been typically undefined. It's very passive, just even looking at health disparities in programs and research. Next slide. So when we like to think about smoking cessation, oftentimes what comes up is the concept of the trans-theoretical model and the stages of change. So smoking cessation exists as a process, and we know this rather than a specific event. And so part of smoking cessation is having an understanding of how race impacts the trans-theoretical model and of change across the quitting continuum. And having that information can provide impactful pieces that can inform and develop appropriate population-based interventions for community. So a little bit about the trans-theoretical model is that it was developed by Praschka and De Clemente in the 70s. And it was a model that was used to describe the journey of a person's decision-making in substance use across a continuum. So, and in the context of smoking cessation, the trans-theoretical model assumes that change isn't instantaneous, it's not linear, it's rather more of a continuous process of intentional or unintentional thoughts, any changes, habits made by an individual in their pathway and readiness journey towards change. A piece to add in there just to reflect on as well is, we know when we think about the stages of change, we don't necessarily account for relapse. And I just want to be very clear about that piece as well, because relapse is a part of recovery and is inevitable, but isn't necessarily featured in this model in the same way. So I wanted to note that. But when we talk about smoking cessation in particular in ACB communities, African Caribbean Black communities, there are main gaps that exist in the therapeutic relationship between healthcare providers and those who identify as ACB or African Caribbean and Black. And those relationships can have an impact around how people adapt to the trans-theoretical model. So having culturally sensitive knowledge and information is really critical to how people adapt to the stages of change. So the three gaps in care here are, the one piece is the lack of adequate representation. So research has found that overall Black individuals are less likely to use NRT, so that's nicotine replacement therapy, and its effectiveness in promoting smoking cessation is limited because of that connection. So that kind of leads us into the idea of lack of representation. So when people see folks that genuinely look like them in the healthcare setting supporting their case, it changes how people interact with the trans-theoretical model and also just how they identify with smoking cessation in general on a fundamental level. And then the last piece here is just around culturally adapted approaches to care. As our last slide had mentioned, we don't necessarily have enough understanding or research and program implementation specifically around smoking cessation for ACB communities. So I'll kind of take it away and let Kevin tell us a little bit more about that relationship.
Thanks so much, Safia. And I promise, Jama, I will stick to my time here. This very much so could be a presentation on its own, but we just wanted to make sure we touch on certain topics just to kind of set the stage and level the playing field for folks in better understanding why this work is important and why it's needed. So I'm sure a lot of folks have heard of anti-Black racism, especially over the last few years. There's been a big push for education. I don't know if that cut out, I'll repeat that. There's been a big push for education about what anti-Black racism means, and particularly in healthcare spaces over the last bit. So the term was first coined by Dr. Akua Benjamin to kind of highlight the understanding of systemic racism, as well as the experience and history of slavery, colonialism, and how that has impacted Black communities for a long, long time. I think sometimes when we consider anti-Black racism, we're kind of looking at the policies and practices, which are, if we look at the Canadian context, rooted in Canadian institutions, such as the education system, healthcare, justice system, you name it, across the board. Sometimes it's displayed in different ways. So when we look at systems like the justice system, we might see overrepresentation in systems where you wouldn't want to be overrepresented. And when we look at things like education system, we might see underrepresentation in spaces where there's positive health benefits from having increased representation in those spaces. One thing to understand about anti-Black racism, or one of the many things to understand, is that it can create significant stress on the body. I know sometimes we talk about the idea of race-based trauma or race-based traumatic stress. So the understanding of navigating these systems and having to continually navigate and advocate for yourself in spaces, there's a toll that's played, and sometimes we don't name that, especially in the mental health spaces. But this can trigger a lot of negative or maladaptive coping strategies, such as smoking, which later leads to further morbidity and mortality rates. Anti-Black racism is key in understanding social determinants of health as it relates to African Canadian and Black populations. So when we look at different understandings of the social determinants of health, we can look at income and social protection. So having less adequate income or less likely to access social income supports. So I know Safia talked about, for example, nicotine replacement therapy and some of the costs associated with that. So that might be an intervention, for example, that we know is effective. But because of income insecurity, sometimes maybe less access to things like that. So understanding that from a smoking cessation perspective. Also understanding that education rates and smoking sometimes are linked. So sometimes having less educational attainment because of many systemic barriers. Unemployment or underemployment sometimes, or even just not having job security, leading to financial stress, which leading to some of those self-medicating behaviors and pieces like that. Work conditions, food insecurity, housing insecurity, having the basic amenities needed in housing, child development programs that are early intervention, you name it, across the board. So it's important to note as well on this point that anti-Black racism doesn't necessarily place the blame on individual factors. We're looking quite broadly at systemic factors. And not to say individual can't be there too, because it certainly can, but that's a presentation for a different day. But when we're looking at the systemic pieces, it's not necessarily just a hatred, right? We're looking at a broad skepticism sometimes that is placed in certain communities and more broad optimism in other communities. So when we specifically look at Black communities, that broad skepticism has negative impacts on health, on the way Black communities sometimes perceive themselves and kind of internalize some of those feelings, which kind of leads to many behaviors that we're hoping to target. And I talked about stress and self-medicating. Of course, we know that that's a common theme and common link. So when we consider all this together, I think it's very important to name the impacts in terms of anti-Black racism on understanding stress and stress responses. If I can get the next slide. So where do we go with understanding that? So this piece here about culturally responsive care. Sometimes I think this is a new phenomenon for folks, because I know sometimes the words that we're using, cultural sensitivity, sometimes there's many different terms, cultural humility, and each, of course, meaning a different thing. I think we tend to lean on this idea of cultural responsive care for many reasons. So first, just to kind of set the stage of what that means, so paying attention to the social cultural differences between those receiving care and the environment in which they are accessing care. I tend to like this culturally responsive lens versus kind of just the idea of cultural sensitivity, just by nature of the word responsive, it being a verb, it's an action word, right? Sometimes when we look at cultural sensitivity, we kind of say, okay, there's a spectrum. I've learned so-and-so, I've studied, or I've been working with this community for so long, and now I reach this place of competence. And I think that's sometimes a problematic understanding, because we can never fully be competent in any culture, even our own cultures, right? There's so many different nuances and cultural specific pieces that I think understanding the idea that we can reach this finite place where we feel that we know everything can be problematic, because then we stop listening, right? So this responsive piece, it's almost a call to action, right? We're recognizing the needs of communities and we're committing to do something about it, right? So it's about understanding, how can I assess what your needs are, and how can I tailor my intervention in a way that's responsive to those needs, versus just being sensitive or recognizing it and not necessarily having that commitment to follow through. So in terms of being intentional and consistent, recognizing those cultures, I spoke about that a bit. Utilizing tools can be helpful. So sometimes if there's culturally responsive or culturally adapted tools that are measuring certain pieces, we've been pushing for that a lot. Better research and understanding how certain screening tools can be shaped and shifted to understand and explore cultural lenses as well. So not just kind of the one size fits all, this is how we screen for this concern. How does culture impact use, for example? So those are all pieces that we should consider across the board and care for clients in the healthcare system. If I can get the next slide, and I will pass to Jama to get into the meat of what we've been doing with this project so far.
Perfect. Thank you, Kevin, and thank you, Safia. So Kevin and Safia both provided some very well-needed context and some help us contextualize or conceptualize a lot of the key themes and key ideas that kind of went into the planning and the designing of this project. And this is essentially what our project is. It's trying to improve cessation outcomes within Black communities across the GTA. So just to give you some background information on the project itself, it's a 2-year project that was funded by the Public Health Agency of Canada under the Healthy Canadians and Communities Fund. So this fund aims to improve health by supporting interventions that prevent chronic diseases and addresses one of 3 risk factors. So there's physical inactivity, unhealthy eating, and tobacco use. So you can clearly see where we lie on that spectrum. And the project is designed in collaboration with CAMH and Black Health Alliance, alongside other partnering agencies as well, such as the Caribbean African Canadian Social Services, CAFCAN, as some of you may know it as, and Taibu Community Health Services, both of whom, or all 3 of them, who are organizations that primarily serve Black communities across the GTA. So the aim of this project is to design a culturally responsive and relevant smoking cessation program that is specifically tailored towards the needs of diverse Black communities across the GTA. And we say diverse because we want to capture the many voices and lived experiences that can be found within the community. As Kevin mentioned, you can be from the same culture, but there are different nuances even within that culture as well. And what we want to do within this presentation or within this project is to capture those nuances. And this is done by using a community-based participatory research approach. So this approach, it recognizes the importance of involving members from the target population as active and equal participants in all project phases. And this is done to ensure that the community's priorities are addressed and that their health and well-being is essentially at the core of the project. And why is this important? Well, it's very important to apply these main tenets of CPBR to consider the lived experiences of our participants in regards to anti-Black racism, culture, language, intersecting identities. There's so much that goes into an individual and so much that ties into their culture. We want to make sure that that is reflected within our project. And we also want to empower participants to kind of share their thoughts and feedback to generate the ideal knowledge. And one way that we're applying the main tenets of CPBR is by engaging with our advisory group, which Kevin will kind of go into a bit more. But overall, the goal of our program is to reduce the harms associated with tobacco use and the risk of chronic disease. So one of the activities that we have done is forming an advisory group, and I'll let Kevin kind of speak on to his experiences in terms of that formation of the group and what it looks like on a day-to-day basis.
Thanks, Jama. So yeah, the advisory group, there's a lot of thought and consideration that all the members of our advisory group put into kind of what that group needs to look like. So again, as we can see on the slide here, having a mix of researchers and clinician scientists, subject matter experts, people with lived experience. But we really wanted to center the lived experience through all aspects of the project. So that's been really a push and a focus to make sure that we have those voices of lived experience. Sometimes, of course, and I know Jama will talk about some of the challenges in terms of recruitment and pieces throughout this presentation, but making a conscious effort to have that as an agenda item and to explore different avenues in terms of how we can put together a group. So it's not just, the so-called quote unquote experts in the room trying to have a discussion and then trying to bring conversations to community. But how can we kind of lay the stage to have those perspectives and those voices at the beginning? I think also as well in terms of just collaboration and partnership, so partnering with Black communities and Black serving organizations from the onset as well. coupled with a lot of the expertise and experience in terms of subject matter expertise in terms of smoking cessation with the team here at CAMH, and just collaborating at the onset to make sure that the design considerations are from the forefront. So I think kind of speaking to that process you just referred to, Jama, we want to make sure that we were being purposeful in that, and it's not kind of that tokenistic representation that sometimes if we're not being cautious to be purposeful, we can kind of fall into that pitfall.
Yeah, and Kevin can attest to how many things that we kind of come back to the AG with on a weekly basis, just making sure that everything that we do is essentially informed and is going through the right procedures, and to ensure that we're being true to the core values of CPPR. We've also conducted both a literature review and an environmental scan to better understand the current gaps or the current evidence that exists to support smoking cessation within Black communities in Canada and subgroups of Black communities as well. The review and the scan helped us identify gaps in evidence and on effective smoking cessation interventions for Black communities. And for the past few months, we've also been hosting focus groups and plan to host individual interviews later on in the year to encourage participants to share their experiences using tobacco and what they think they should be included in a culturally responsive smoking cessation intervention for Black communities across the GTA. So here is a bit of a timeline to kind of just give you an understanding of what our project looks like. So we kind of find ourselves right in the middle of recruitment and focus groups, mostly because we're recruiting as we're conducting focus groups, so we're doing both simultaneously. And I'll get a bit more into focus groups later on in the presentation. But we're hosting, what we want to do is to also go more in depth on the things that emerge out of focus groups in the individual interview phase. And then we'll also talk about all these different factors or all these different parts of the project in more depth as I continue. So now we'll kind of go into what we found from the literature review and the environmental scan. So the environmental scan, the purpose of it was to really identify any existing smoking cessation programs, initiated resources, or services that were developed alongside or tailored towards diverse Black communities in Toronto and in Canada overall. And this was done in 2 stages. So on the first stage, we conducted a Google search that focused on Toronto and across Ontario. And what we also did was we targeted a few community agencies within specific regions in Toronto, these regions being Humber River, Etobicoke North, and Northeast Scarborough. The reason being that these are the areas within Toronto or the regions within Toronto that have the highest percentage of Black populations residing in them. And what we did was we reached out to family health teams, community health centers, and nurse-led clinics, nurse practitioner-led clinics that currently implement our STOP program, STOP being the CAMH smoking cessation program. And we asked these organizations 2 questions, which I'll get into just in a bit. And in the second stage, we conducted a very similar Google search, but we broadened it up to within Canada overall. So just some results. So of the total 16 search terms that were related to smoke cessation services in Toronto and Ontario, we found nothing, essentially. There were no results that were found. And this example search term gives you an idea of what we were looking for, essentially. In terms of our community outreach portion, I mentioned that we asked 2 questions. The first question was, does your organization currently have any smoking cessation initiatives or practices in place specifically tailored towards Black populations? And do you know of any organizations that might be doing said work across the GTA or in Ontario? And what we found that no healthcare organization was really had any kind of programming that was specifically for smoking cessation for Black communities. We asked some of the healthcare providers that attend a STOP teleconference, which is held, I believe, every month with our different CAMH STOP sites. And we asked them if there was anything that they could recommend or if there's anything that was going on. We were able to kind of identify 7 different organizations across the GTA, many of whom that were Black serving organizations, to see if they would have any services that were being offered. But we realized that there was nothing really being offered in the way of smoking cessation for Black communities. Some organizations share that they have a more of an inclusive approach rather than a targeted approach to treatment, and some organizations mentioned that while they do have targeted approaches, it is mainly for the communities that they serve. So one of the organizations mentioned target approaches for the Tamil community that they serve, but not necessarily anything specifically for Black communities. The second question that we asked was that, did they have any thoughts on how to tap into these populations that are not typically reached by traditional healthcare services? And what we found was that they tend to target, that we should target organizations, or we should target communities more directly to really understand and to really highlight what their needs are. We want to develop we should develop relatable materials and recruitment materials when reaching out to community members. They mentioned that we should have Black-led and Black-serving organizations lead smoking cessation initiatives targeting Black communities to kind of champion these initiatives and these projects, to provide language translational services, to ensure that services are accessible and affordable, if not free, and to understand that while smoking cessation might be an issue that needs to be addressed, it might not be an individual issue that Black individuals see within themselves. There might be other pressing issues in their lives that kind of come first, and that smoking cessation is just not on the top of their priority list. So also trying to take that into consideration as well. So in conclusion, we basically, in the second stage, we actually did the very similar search terms, but what we did was we broke them down to provinces and territories across Canada. Long story short, we didn't find any relevant results. So what we found was that essentially that there is a big gap. There is a big gap in services not being offered towards Black communities in Canada. And while that is very much what we see across many different avenues of healthcare services being offered, this is one that we feel like it can be addressed through the confines of our project. The next activity that we did was a literature review, and the purpose of this was to present the current evidence to support smoking cessation for diverse Black communities. Essentially, what we wanted to do was to answer two questions. So what is the current evidence that exists to support smoking cessation for Black individuals in Canada and subgroups of Black communities? And are there any gaps in evidence on effective smoking cessation treatment? So the literature review was done in two stages. The first stage was in the Canadian context, while the second stage would have been in the UK and US context if we were unable to find anything within Canada. So we also conducted a gray literature search of key databases, and a customized advanced Google search was done, and we used some clinical registries such as Health Canada Clinical Trial Base, Trial Database, and Pan-African Clinical Trial Registry as well. And we also had some inclusion criteria for our gray literature search, such as dissertations, conference proceedings, community reports, a variety of things. And we found some of these stuff from Black Health Alliance, who provided some resources, the Government of Canada, the Center for Black Health and Equity, and Smoking Cessation Leadership Center. So what we found in the Canadian context was nothing. We didn't really find any kind of results in our first stage. So when we moved on to our second stage, we found that it yielded about 49 results, which included systemic reviews, RCTs, cohort studies, and cross-sectional studies, as well as opinion papers. But in both stages, the gray literature searches didn't really yield any relevant results to us. So what were some of the key findings from the literature review? We found that pharmacotherapies were found to increase abstinence rates, but mostly in the short term for Black populations. Sustained-release bupropion was most effective in helping Black individuals quit smoking, and studies have found that while church-based interventions were effective, their results were short-term or short-lived. Some studies also found that using more direct and tailored approaches were more effective than impersonal approaches, and some of these direct approaches included addressing the needs and barriers to quitting smoking specifically for Black populations or for Black individuals, highlighting the benefit of quitting smoking, as believing in the harms associated with smoking and the benefits of quitting smoking were more likely to elicit more quit attempts among Black individuals. It was also important to have more face-to-face direct contact and involving the community residents in any kind of community projects that were being held. It was also shown that Black individuals who smoked were significantly less likely to receive any quitting advice from their healthcare providers compared to white individuals. And this wasn't a way of saying that Black individuals were less trusting of their primary care providers, but they expressed frustration in the fact that they were not getting adequate smoking cessation counseling from those who they're reaching out to. So some recommendations that we found from the literature was to combine different quitting strategies. These can be behavioral strategies, counseling, medications, as kind of intertwining them can really help lead to more effective quit attempts. We could also target earlier stages of smoking cessation, lower the cost of medication, and build meaningful relationships and partnerships within Black communities. So here is an example of how we've used that information from the literature review to kind of create some knowledge pieces. So this is a infographic that we developed, and we're sharing it with our focus group participants so that they have an idea of what is out there in terms of research, what various ways they can kind of consider quitting smoking, and what strategies have been shown to be most effective within Black communities. So what are we doing now? So we're currently hosting focus groups, and we're continuing, and we're continuing to host them and inviting Black community members to live or access services in the GTA to participate in them, to elicit their experiences with tobacco, including experiences with racism, and how these experiences impact their tobacco use. What we want to explore is what their experiences are and what are the needs and priorities and preferences of Black individuals who are looking for smoking cessation services in Toronto. Each focus group is approximately 2 hours in length, and they've been co-facilitated primarily with Kevin and I, but also with other members of our advisory group from the Black community. And these include a healthcare provider and a member from a partnering agency. So what is our eligibility criteria? First things first, self-identify as Black. I think is that's been very clear throughout our project. But being 18 years or older, sufficiently communicate and speak English, smoke tobacco products. These can include cigarettes, cigars, graba, which is tobacco leaf mixed with marijuana, or be in the process of quitting or having quit in the past, and currently accessing services within Toronto or the Greater Toronto area. So as Kevin mentioned before, there were some recruitment challenges that we faced initially, and I think this was mostly led to the fact that there was a bit of a disconnect in how we were engaging with our communities. We were trying to get our community members to reach out to us to join the project, where it would have been more helpful for us to bring the research or bring our project to the community. So essentially, we started off with sharing our project flyer with community agencies and organizations, emailing healthcare providers, and through just word of mouth and social media. But the approach felt way too formal, and we weren't really getting enough engagement. What we decided to do was to begin doing more in-person recruitment. So by bringing the project to the community rather than putting the burden on the community, we were able to engage with more people overall. This is not to say that all of our recruitment challenges have gone away, but it's definitely alleviated it to an extent. I'm going to pass it off to Kevin now to kind of share with the group what we found from focus groups thus far.
Thanks, Jama. And I think I just wanted to add a note to just considering the information that you just shared. I think it really highlights why this work is important when we kind of look at all those literature review processes and the lack of hits that we're receiving in terms of literature that's speaking to this. We're really seeking to fill a gap in the literature with some of this research and this project. So that's why, particularly when we look at these focus groups and some of the pieces that we've been learning, we're really hearing from community for the first time in this way, specifically about this topic. So it's been very informative. I can speak for myself, and I'm sure for others on the project or others who have done the focus groups as well, just hearing from participants and understanding what they might like to see in terms of smoking cessation programming and to support them in their journey. So I think one of the first pieces that we've been hearing a lot tonight, I'm sure it's not a surprise to a lot of folks, that quitting smoking leading to kind of those feelings of depression and social isolation. Just to kind of contextualize that with some of the pieces we talked about before, understanding that a lot of folks have expressed to us kind of smoking in community. So whether it's in a work group space or in friends or pieces like that, and sometimes in trying to quit smoking, removing themselves from those environments, but then kind of losing that informal support system. So it's been quite challenging for a lot of folks, and some expressing even kind of feeling isolated. I think it's important to understand that when we're using interventions, or when we're promoting interventions, or if we're talking about smoking cessation, uh, many folks have used that as a self-medication process. So if we're going to remove that process, we should also be considering how do we put in more, or healthier, I should say, coping strategies, right? Because at the end of the day, those reasons that have led folks to want to smoke or to engage in smoking might still exist. So cessation is one piece, but also how do we provide clients or folks who are smoking with the tools so that when they are feeling those stresses, whether it's anti-Black racism or just life stress in general, that they're able to cope with it and not feel like they have to rely on substance use, particularly smoking or using tobacco-related products. The second piece, an increased need for representation in smoking cessation in healthcare services. The focus of this is smoking cessation, so I'll focus on that. I think there's an increased need in healthcare in general, but I will focus more on the cessation piece. There's definitely an increased need to have providers who look like some of the clients who are seeking these services, was said to us. Particularly, there are a lot of participants who kind of noted that having that that relationship might make it easier, not only just kind of open up and talk about some of the challenges, but particularly to talk about some of the cultural related challenges that they've been having in terms of cessation. So, for example, there's some participants who've mentioned in their communities, for example, stigma related to smoking or using tobacco related products, and sometimes not a similar stigma with other substance use as well. So it's hard sometimes to kind of express and kind of put a name to that. They've noted with other providers who aren't as familiar with that cultural background or I don't necessarily look like them who they can resonate with. So they noted having that space might make it safer for them to kind of engage in some of those conversations and to kind of problem solve and strategize in terms of how do I kind of address this family support piece as well. A lack of peer/social supports in cessation efforts. That's been a huge theme. Overwhelmingly so in all the focus groups, we've been hearing a need for peer support or a peer support arm in terms of supporting with recovery. Folks noting that it's much easier to communicate with other folks who understand what it means to have gone through or to have been smoking or to have made a quit attempt and the struggles and some of the challenges that they've been facing in terms of relapse and just trying to work towards their goals. Not to discount the importance, of course, of other providers providing some of that care, but folks particularly noted that having a peer who kind of has that understanding would make it easier. And again, someone that they can have a shared experience and they can kind of resonate with. Having incentivized programming for smoking cessation, I think that's something that I particularly learned in terms of the literature, the efficacy of things like that. But folks mentioned like having an honorarium or things like that to kind of incentivize not using tobacco-related products. And then even more broadly, not even just kind of a monetary piece, but just making sure that the financial structures are put in place that kind of support with alleviating some of the challenges related to social determinants and accessing. So folks mentioned having childcare available, for example, so that they can participate in programming. Ensuring that there's food or transit, and we're in Toronto, so here particularly with CTC tokens or things like that to help folks be able to get to and from appointments. So that was a big note as well. Having incentivized programming, I just noted that. So the last piece there in terms of interest in participating in culturally driven and responsive smoking cessation programming. So I think this was an interesting one as well. A lot of the participants noted that, for example, having the cessation program rooted in a community where there's increased representation of Black communities would be helpful because it would feel like a safer space to kind of go to and access. So kind of removing some of the programs from the kind of the ivory tower model where folks are coming into large institutions, and more so are there ways to kind of place these programs in communities so that they're in spaces that folks are already accessing. Apart from that, I think particularly was noted kind of having these cultural nuances woven into the curriculum, if we're talking, for example, psychoeducation or health education. So talking about race and culture and the impacts of that and having that built into programming as well. Because for a lot of folks, that's a significant factor in having the space purposefully to discuss it, again, goes into that idea we were talking about before of culturally responsive care. Get the next slide, and I'll pass back to Jama, who will let us know where we're planning to go.
Yeah, perfect. Thank you, Kevin. Yeah, so I'm going to show us kind of where we go next. So after our focus groups, what we plan to do is to really analyze the data. So the data that was generated from our focus groups will be analyzed using reflective thematic analysis. And we use reflective thematic analysis as an approach as it really values the researchers' subjective experiences as the primary way to discern knowledge from the data. And this kind of goes in hand with CPBR because what we want to do is not just remove bias or objectivity, but we want to use those lived experiences and those values as a primary tool to really make sense of the data that has been generated. And this data will also be interpreted using critical race theory to help develop the themes. And based on those themes that emerge from the focus groups, as I mentioned before, an interview guide will be developed to contextualize and to provide more in-depth information regarding some of the key concepts that were discovered or that were discussed during focus groups. So the interviews will be about 16 to 20 with the individuals who have participated in our focus groups, and it'll be a one-on-one individual interview setting. And the idea is to kind of just delve deeper into these themes that emerged, provide an opportunity to discuss the complex relationship between systemic issues and individual experiences in that one-on-one setting. And the guide will also be co-developed by myself, and members, individuals people with lived experiences. So what we want to do is to make sure that every stage, every part of this project is being informed by lived experiences from community members to ensure that we are really addressing the critical needs that are being highlighted by the community. From there, we will kind of go into the evaluation piece. So what we plan to do is to evaluate the extent to which the results of our focus groups and our interviews are acceptable, relevant, and feasible. There's a need to kind of follow up and to evaluate the long-term impact and sustainability of CPBR projects or community-based participatory research projects to determine how the findings are being implemented and scaled up and to investigate their success and societal impact. And we also want to explore the perceptions of the community members, experiences participating in focus groups and individual interviews as a part of community-based participatory research. So some of these areas that we want to address, so acceptability, essentially what we're going to be looking for is, do the individuals who took part in the focus group and individual interviews, do they think that the results were agreeable? Do they think that the results were relevant? What is the perceived fit of the results from the focus groups and interviews with regards to a smoke cessation program that we are trying to implement? And how feasible are these results? How feasible are the recommendations from this project? And how can they be carried out as intended with the existing means, resources, and circumstances? So that kind of concludes the content of our presentation. That talks about our project and just kind of the background information. And what we wanted to do was to kind of present just another poll. So I'm going to share my screen just once more. And what we wanted to do was we wanted to understand or want to get a better feeling of how your understanding has changed as a result of this presentation. So how would you describe the change in your understanding of smoking and smoke cessation within Black communities after this webinar? So you can go on Mentimeter again, and this time you'll just type in a different code. So 17682395. I should have hidden the results. So I'm gonna do that. And let's see the results kind of just flow in for a second. So how has everything that we kind of described, the culturally responsive care, understanding what community-based participatory research is, the thoughts of, how can we use these methods to engage with community members to develop a program that is both specifically tailored to them, that is responsive to their needs, and that is something that is going to address the concerns that the community has. I'm going to give it just a few more seconds before I close it up because we did have one more question that we wanted to pose before we give you an opportunity to ask us some questions. Okay, I'll close the voting now. All right, let's see some of the results. Okay, awesome. Well, I'm glad that we were able to kind of address some of the questions that you might have had kind of coming into this presentation. And that we will also, I know that Rachel mentioned that we will share these slides with the individuals later on. So hoping that this can be a resource for you all moving forward. But before we do end off, what I wanted to do was what we wanted to do was to pose a question to you all. And you can provide your answers in the chat, and we can kind of just go through some of the comments for a bit. But what we want to know is, how can you apply what you've learned today to your own practice? And if you're not within the field of smoking cessation, just thinking about those themes of community-based participatory research, culturally responsive care, thinking about anti-Black racism, how can those themes and those engagements with community members really inform your practice? And I think maybe what we might do, hopefully, if this is okay, is if we can also offer the opportunity to ask questions as well. So if you want, if you can, please provide your response to this question. But if you did have a question that was related to the presentation as well, then please leave those in the chat, and we'll try to address those as we can. So Aaron mentioned, how can we think critically and adapt our smoke cessation program and mobile application to better support Black youth within smoking cessation? I'm not sure if this was a question that you're asking us, or this is what you were thinking about in terms of how you want to apply it, but maybe provide a bit more context to that. Not a question, but it's not. Okay, cool. I thought you were putting me on the spot, Aaron.
I think that's an important reflection as well, because I know in some of the literature that we looked at, and a lot of the subpopulations and Black youth kind of being one of them. So just kind of how do we kind of center the voices of youth more so in kind of the design of programming? How do we think thoughtfully in terms of who we're not reaching, and where are they, and why aren't we reaching them? Those are all great considerations.
And I think it's also important to remember, just like how we were able to kind of address our recruitment to bring the project to the community, it's important to bring your project to the individuals that you are trying to serve. So how can we kind of, come down to their level, not come down, but to come up to their level, and to really see them level on and understand what it is that they need, and how can you address those? Eva mentions that applying some of these learnings towards diverse recruitment strategies, recognizing that there is a gap in knowledge, so sometimes or oftentimes that there is a need to be innovative and creative. And yeah, I think that is very, very true. I think it really is dependent on the target population that you're trying to reach. And it's really important to understand that it's not a one-size-fits-all approach, that you need to tailor it based on the needs, the specific needs of the community that you wanna work alongside. And Aaron also asked if we will be sharing our contact information as well. And that is just a few slides down. I believe our emails are added to these slides. So if you have any questions, then feel free to reach out, and we'll definitely love to connect with you. But yeah, so we have some references towards the end here. So by all means, please expand your knowledge as much as possible. Read some of these references or these resources. They're great resources to have. Again, we're very much open to questions. If you want to continue to populate them in the chat, that'll be great. But also, we do have our contact information on the slides here. So please feel free to reach out if you do have any questions, and I'll kind of pass it on to Kevin and Safia to give us some closing remarks as well.
On my end, I'd just like to say a huge thanks to the whole team, everyone involved in the advisory group. It's been a lot of learning for me on my end, and hopefully for other folks who've been engaged in that process. But it's also eye-opening through this, I think, over a year now or so that we've been engaged in this, to see how much more work is needed to be done in this area. And I think some of the challenges even that we've been kind of having in terms of recruitment and some of those pieces, just to understand that there's a lot of work to be done to better engage these communities. But I'm glad that we are taking some of the first steps here. So those will be my pieces. And hopefully this was informative for folks on the webinar call as well, and kind of inspiring to consider what can be done in your practices to kind of contribute to the knowledge base as well.
If anything to add to what Kevin shared, I feel like this is a first step of many to developing really innovative practices around how we conceptualize smoking cessation, but even replicated in other models as well when we talk about substance use. So lots to see and lots to learn.
Perfect. Thank you so much, Kevin and Safia, and thank you all for attending as well. And I'm just going to pass it off to Rachel to kind of take us away, to take us home.
Yeah, thank you all for such an engaging and informative webinar. I know I learned a lot, and I can tell from the chat everyone else did as well. I'm just going to finish off with a couple of housekeeping items. So I just want to remind everyone that this webinar has been recorded, and I will be distributing a link to it as well as the copy of the slides to you all by tomorrow afternoon. Please feel free to share with your colleagues. I will also be sending a link to the evaluation and post-learning assessment that should be completed by next Wednesday in order to receive your letter of completion. So I also just wanted to take the time to let everyone know about our next webinar, which will be on March 8th, and it will be on the topic of the menstrual cycle and quitting smoking. And we hope to see everyone there. And if you want to watch this webinar again or see a previous Teach webinar, an archive list can be found on our website. So thank you all for listening and participating today. We hope you all have an amazing rest of your day. And just as a reminder, feel free to contact Kevin, Jama, or Safia with any questions. I'll leave their emails up here. But thank you, everyone.